direction do people usually have, let's get you forward. I know the sticky floor. What direction do people usually have wrist pain with? Do you think extension or flexion, typically? Extension, of course they do. That's our more functional position anyhow. So if I'm going to do a mobilization with movement, it's going to look a lot like your regular joint mob, where I'm going to kind of have my hands here, kind of grabbing that wrist. But what I want her to do is to do the motion with it. So if she's going to do extension, what direction do the carpals glide?
I just use my
anterior.
I think anatomical position, not the way her hands do.
Remember, volardly. The volar, palmar, anterior, but yes, towards the floor. So what I can do, I'm going to try and get my hand out of the way so you guys can see. So this isn't a great hand position. Ideally, I'd be here, but I want you guys to kind of see. So with my finger, I'm going to provide that volar glide as she goes into extension. So go ahead and bring your wrist up for me. And relax. Bring your wrist up. And relax. Bring your wrist up. And again, if they have pain with it, it should be less pain as I do it. If I'm not getting quite the force I want, I can change my hand position and give a little bit more. Okay, a little bit more force, but she's always doing the motion with it. Okay, and just like with the neck, I want them to initiate the movement before I really start doing a glide. If she's having problems with flexion, which is not typical, again, I'd have her bring her palm down, and as she does that, I'd be pulling up into that dorsal direction, okay, with the carpals. Yeah? Super easy and really effective for especially extension, wrist pain. Okay, good. So while we're here, because shoulder's so easy too, can I pick on a shoulder?
Yeah.
Sure, that'd be great. Most common problem that patients have with shoulder dysfunction is that the head of the humerus kind of sits anterior on the glenoid fossa because our lives are forward and we get tight in pecs and we, right? You've seen this patient, right? You've been this person? Okay. So that when that glenoid sits anterior in that joint and they start to go into flexion or abduction, it starts pinching on that acromion process sooner. Does that make sense? Because it's sitting forward. So as soon as they start to try and move, it's gonna hit and pinch because it's not back where it should be to allow for that nice normal roll and glide. So if I want to help, I'm gonna pick on the shoulder because it's closer to me. Actually, let's turn you so they can see. I said I'm like forward. There we go. So, do you have any shoulder discomfort?
No.
Oh, okay. So,
not that I know of.
So let's say that she's having pain with abduction, just because that's an easier one. What I'm going to go ahead and do is I'm going to provide a little bit of a posterior glide. Now go ahead and abduct your shoulder. So bring your arm up now. And I'm just going to sustain that as she goes through and come back down. Go ahead and go all the way up if you can. Good. And come back down. And that's it.
What's popping? Feels good.
I know, I was going to say, now you're good. Now there's less popping.
Yeah.
Yeah.
That's really
And she had a little bit of tightness there.
So is the back hand just stabilizing
Yep.
you?
I'm on the scapula,
Okay.
so that I can bring the head of the humerus closer towards that posterior side, because otherwise if I do this, I'm just retracting her, and I really just want to do that posterior glide. Okay. Works really, really well. If there I could also do, for abduction, a caudal glide with that, so that inferior, so go ahead and come up, and just kind of, oh, that was a little more, that was
you. That one wasn't me.
So you...
So this one I'm kind of pushing down, which isn't going to allow her to come up as far because I'm pushing down on her. But if that's a real problem that they're having is not being able to get it to depress as they come up, that could be helpful. But I usually see this posterior one do the magic for the majority of people. So, and it doesn't have to be a lot of force. So this is not even a grade 2 sustained. This is a little bit more than a grade 1, but not even a grade 2.
1.5.
It's just enough to help relocate the head of the humerus back into the fossa. And then they can do a self-mob super easy. Right? So they just kind of push back and then they can do the exact same thing.
If you wanted to, you have them lean